Hello everyone and welcome to my channel and another video about clinical pharmacy practice. And in today's video I'm planning to talk to you about switching antidepressants. Now this is something we see a lot in practice and it could be confusing to some, especially that there are too many techniques out there for switching from one antidepressant to another. So I'll try to bring to you the most commonly used techniques when switching from one antidepressant to another, and hopefully by the end of this video you'll be able to switch antidepressants without any confusion or any hesitation. Now this topic is particularly important for candidates applying or planning to apply for the PEBC pharmacy exams, especially the qualifying exams, because it has been brought up several times in previous exams. So you might want to pay attention to the video and learn how to do the switch as well, because most probably if you're going to get a question about antidepressants, one of those questions will be about switching antidepressants. And also for PEBC candidates, I have a good bonus for you at the end of the video. If you are looking for a preparatory course, there is an excellent course that I have a coupon code for you that will get you a really good discount. So stay tuned at the end of the video because it might help you or someone that you know that is planning to take the PEBC exams soon. Alright, for those of you who are new to the channel, this channel is all about clinical pharmacy practice. I teach you how to become clinical pharmacists, how to advance your career as a pharmacist, and I also teach you how to pass the PEBC exams, especially the OSCEs. I give you free tips, so make sure to subscribe to the channel and activate the bell so that you get notified of my future videos. Now let's get started with today's presentation, and as usual I have a case for you. JK has been taking mirtazapine 45 milligrams daily for the last 4 months for the treatment of depression. He calls the pharmacy today to report that his symptoms have not improved at all. You are the pharmacist in charge, and so you consult with JK's physician, who would like to switch antidepressants from mirtazapine to sertraline 150 milligrams daily. So it's a completely different drug from a different class here, right? The physician would like to know the best way to do that. Okay, so the doctor doesn't know and he needs your help with the switch. Which of the following is a recommended approach when switching antidepressants? And I give you 4 options here. Number 1, discontinue mirtazapine, wait for 2 weeks washout period, then start sertraline at 100 milligrams daily. Option 2, discontinue mirtazapine, wait for 5 weeks washout period, then start sertraline at 150 milligrams daily. Option number 3, taper mirtazapine over 1 or 4 weeks and at the same time start sertraline at 150 milligrams daily. Or option number 4, taper mirtazapine over 1 to 4 weeks and at the same time start sertraline at 50 milligrams daily with slow titration up to 150 milligrams daily. Now here's what I want you to do. I want you to try and solve this case and write in the comments what did you choose before you go through today's video. And the reason I do this, or I actually like to do this even with my students, is because the way you solve it now, based on your train of thoughts, based on your previous experiences or previous reading that you read about antidepressants, and then later on when we go through the case altogether will actually help you retain the information for a longer period of time. And most of my students tell me that. This is what I do. I give them a case. I tell them try to solve it on your own without reading anything about it, without researching, without going through my material. And then at the end of the lecture or presentation, we go through the case together and we figure out the answer. And most of them end up retaining that information for a really long period of time. Even as a clinical pharmacist in practice, this has helped me a lot, and hopefully it will help you as well. And there's no right and wrong at this point. So even if you answer wrong, it's okay, because at the end of the presentation, you're going to compare what did you answer before and how did your answer change at the end of the presentation. If your answer doesn't change at the end of this presentation, then there's something wrong with your train of thoughts and you need to figure that out and work on it. All right, you can pause the video right here, answer the question, and then we'll resume it later to see what the presentation is about. Now, a few definitions. I'm not going to dig deep into the definitions of depression and how to diagnose it. If you are interested in learning about that, you can read more about it on the DSM manual. But just as a general definition, depression is a common but serious mood disorder. It affects thousands and thousands of people today. It causes severe symptoms that affect how you feel, think, and handle daily activities such as sleeping, eating, and working. To be diagnosed with depression, usually you must be present. Usually symptoms must be present for at least 2 weeks. And to learn more about that, just refer to the DSM manual and the guidelines of treatment of depression. There are different types of depression. It's not just major depression, and that's the reason why I brought this slide up here. Again, I'm not going to dig deep into each and every type of depression, but I just wanted to raise awareness about the different types of depression, especially perinatal depression, which is unfortunately underdiagnosed until today in several parts of the world. Yes, perinatal depression exists. Yes, it could be fatal. So please try to raise awareness about that wherever you are. And of course, major depression is the most common or commonly seen cases in practice. The common signs and symptoms: persistent, sad, anxious, or empty mood are always most of the time there in depressed patients. Feeling hopelessness or pessimism too. Feeling irritability, frustration, or restlessness, feeling guilt, worthlessness, and helplessness, the loss of interest or pleasure in hobbies and activities that the patient used to love to do before, decreased energy, fatigue, or feeling slowed down, difficulty concentrating, remembering, and making decisions, difficulty sleeping, morning awakening, or oversleeping. There are so many symptoms. Again, a depressed patient might not encounter all of these symptoms altogether, but at least a few of them, and usually they are there for at least 2 weeks. But yes, there are too many signs and symptoms. Some of them might not even be mentioned here. Right, moving on to the next slide. I tried to bring up the most commonly known antidepressants in the market and their mechanisms and dose ranges, but again, I might have missed any medications here. These are the commonly used in my opinion. Of course, the most commonly used class of antidepressants are the SSRIs and the SNRIs, but there are other classes such as mirtazapine here, which is an alpha-2 adrenergic agonist, and also a 5-hydroxytryptamine 2 antagonist. This is also a very commonly used drug. And then there is the bupropion, which is a norepinephrine and dopamine receptor inhibitor. So there are too many different classes today. TCAs are still barely used for depression, but they are still there as a second-line drugs. The tricyclic antidepressants. MAOIs, monoamine oxidase inhibitors, are third in line, so we don't barely see them in practice anymore. Again, if you're interested to know when do we move from first line to second line or third line, I would ask you to refer to your references or to the DSM manual or to the pharmacy course that I'm going to mention at the end of the video. The dose ranges are basically the minimum dose effective for depression and the maximum recommended dose by the FDA. So you should be aware and familiarize yourself with the minimum and maximum doses of the most common drugs, not all of them. because that can affect your answer in exams if you're planning to take the PEBC exams anytime soon. Alright, so moving on to the next slide. How long shall we wait for a response from an antidepressant? Now, this is very important because you don't want to stop an antidepressant too early and say it's not working, and you don't want to keep it going for a really long time and hoping that it might work one day. And certainly, you don't want to keep increasing the dose and exceeding the maximum dose, hoping that one day the antidepressant will magically work and cure depression. So early improvement, defined as more than 20 to 30% reduction from baseline or on a depression rating scale, after 2 to 4 weeks, is correlated with response and remission at 6 to 12 weeks. That means a patient getting started on antidepressant and has been on it for 2 to 4 weeks. If that patient shows improvement in symptoms of 20 to 30% reduction in depression symptoms, that's a good prediction of the fact that this patient might be depression free in 6 to 12 weeks. On the other hand, the lack of early improvement at 2 to 4 weeks is also a predictor of later antidepressant failure or non-response. So basically, you'll see in most references, an antidepressant should be tried for at least 4 to 6 weeks before you can judge whether or not it works, but not more than that, and definitely not less than that. But within the first 2 to 4 weeks, the patient must see some reduction in their symptoms, and by that we can do an early judgment whether or not to titrate the dose up to a higher dose, or maybe it doesn't work, then we'll switch to a different drug in 6 weeks. Right, moving on to the next slide. Switching antidepressants. Now, when it comes to switching antidepressants, you could switch from one antidepressant to another within the same class, or from one antidepressant to another antidepressant from a different class. What do I mean by that? You can, let's say the patient started on an SSRI and you want to switch to another SSRI. You can do that. There is no harm from doing that. Or let's say the patient started on an SSRI and you want to switch to an SNRI. You can also do that. Or a norepinephrine dopamine receptor inhibitor. You can also do that. There's no wrong in doing that. Generally, there is no need for a washout period. Now, this is the rule of thumb here. You don't need a washout period when you're switching from one antidepressant to another. Now, there are some exceptions to this rule of thumb, but this is the rule of thumb for most of the commonly used antidepressants. The first line antidepressants that we showed you, or I showed you on this slide here. And I'm going to talk about the exceptions later, but before I talk about the exceptions, I want to tell you about the most commonly used technique for switching antidepressants, which is the crossover technique. Crossover technique is basically reducing the dose of the current antidepressant and at the same time increasing the dose of the new starting the new antidepressant at a low dose and increasing its dose gradually. Let's take an example to apply that. Let's say the patient has been titrated on citalopram until they are now on 40 milligrams daily. The patient has not shown any symptom improvement in the last 6 weeks. And now they're on 40 milligrams or 30 milligrams in the middle. Let's take something in the middle. 30 milligrams of citalopram. No symptom improvement. So the doctor decides to switch to paroxetine, for example. It's another SSRI. Fine, you can do that. So to do the crossover technique, you have to drop the dose of citalopram first. So if the patient took 30 milligrams today, tomorrow start with a 20 milligram. Drop it to 20 milligram. And then at the same time tomorrow, start paroxetine at 20 milligram, which is the lowest dose in this range. So the patient basically will end up on 2 different SSRIs or 2 different antidepressants at the same time simultaneously. But we have reduced one of them and started a new one. This way, you reduce the risk for serotonin syndrome, you reduce the risk for withdrawals, and it has proven to be very safe. And then a week later, you drop the dose from 20 to 10 of citalopram and increase paroxetine from 20 to 30, and so on until you reach the good dose for the patient of paroxetine, which the patient is actually responding to. And also, you eliminate citalopram altogether. So after 10 milligram, you can drop it to 5 and then discontinue citalopram. So over 1 to 4 weeks, you basically taper it off. And that's what we mean by the crossover technique. And this is basically the most popular method for switching antidepressants, and the one method that you will see a lot on exams, especially PEBC exams. They will always show you the, or on the answers, you'll always find the crossover technique there, and that's usually the correct answer, okay? Now, what is the other technique that we use commonly when switching antidepressants? It's the direct switch technique. And this is a pretty aggressive technique, because you stop the first agent cold turkey, and on the next day you start the new agent at its therapeutic dose, or you can start at a lower dose, lower than the therapeutic, and titrate slowly to avoid any risks of serotonin syndrome or anything like that. So if we take the same example, citalopram was at 30 milligrams, you stop it completely. So you gave the 30 milligrams today, then you stop the citalopram, and tomorrow you give paroxetine at a middle dose, say 30 milligrams, and then titrate it. Or you can start at a 50 milligrams of paroxetine. It doesn't matter. That's how the direct switch is. This is not very common, but some clinicians still do it, and usually they are psychiatrists, so they are very experienced in monitoring side effects on patients, and they know how to deal with the side effects. So we don't see this very commonly in internal medicine or let's say general medicine, because they don't have the experience and they're very busy. They don't have the time to monitor the patient after the switch. But a psychiatrist knows, and a psych nurse knows very well how to and what to monitor for when we do such switches, such aggressive switches, I should say. So most probably you will not see this direct switch on any of the exams, because it's not very common, not very popular, but you will definitely see the crossover technique. So try to memorize what I told you today about the crossover technique. It's not difficult. Basically, you taper one, you start the other one at the same time, and you titrate it. That's that's as simple as it is. Now, what are the exceptions I told you about earlier, or I told you I'm going to talk about earlier? Those are the MAOIs, basically. So when you see a MAOI, a monoamine oxidase inhibitor, or fluoxetine, you should stop a little bit and think about it, because that's when you need to do a washout period. Remember, I told you generally we don't need a washout period, but if the question includes a monoamine oxidase inhibitor or a fluoxetine, then you have to stop and think about it a little bit, because switching to and from a MAOI requires a washout period, and switching from fluoxetine to a MAOI requires a washout period. The washout period could be different from one if we're switching to or from a MAOI. So if you're switching to a MAOI, you only need a 5 half-lives washout period. And if you're switching from a MAOI, you need a 2-week washout period. These just need to be memorized as they are. Switching fluoxetine to a MAOI requires a 5-week washout period, and that's because fluoxetine has a really long half-life. That's why it requires a really long washout period. And finally, switching from meclobamide to other antidepressants require a 5-day washout period. So just memorize these as they are. Take notes right now and memorize them as they are. In case you see them on your exam sheet or in practice, which is very uncommon, then you should know how to, that these are the ones that require washout periods and how to do it. Okay, so now that you know how to switch antidepressants, let's go back to our case for today and see how did you answer it. Let's go through the answers. The first one says discontinue mirtazapine, wait for 2 weeks washout period. That's immediately wrong, and you can eliminate this answer right away because we say that generally we don't need a washout period unless it's involving a MAUI or fluoxetine, which is not the case here. We have mirtazapine and we have sertraline. None of these are MAUIs or fluoxetine, of course. So you can eliminate answer number 1. Answer number 2 says discontinue, wait for 5 weeks washout period. Again, it has a washout period included, so you can eliminate answer number 2 as well. You see how much time we saved on answering those cases. Option number 3, taper mirtazapine over 1 or 4 weeks. I like that. And at the same time, start sertraline at 150 daily. Now, if you know that 150 daily of sertraline is actually a high dose, you would immediately eliminate that because you don't taper and start a high dose. There is still a risk of serotonin syndrome here. So that eliminates this answer as well. But let's say you don't know that sertraline 150 is a high dose, then keep this option and move to option number 4 to see if it also makes sense or not. Option number 4 says taper mirtazapine over 1 or 4 weeks, and at the same time start sertraline at 50 milligrams daily with slow titration to 150. Now that makes much more sense than number 3 because it's well organized. It has a titration schedule plus a taper schedule, so it looks actually professional. So that can help you eliminate answer number 3 and go with answer number 4, especially if you are aware of the serotonin syndrome risk. So answer number 4 is actually, or option number 4 is actually the correct option. If you got that already at the beginning of the video, congratulations. If you haven't gotten that at the beginning of the video, I hope you did now at the end of the presentation. If you did not, then I would suggest you read more about the antidepressant switches. Another reference that you can refer to is the therapeutic choices. I believe there is a part where they talk about the antidepressant switches in resistant depressed patients. So I'm not sure if the older versions of therapeutic choices have it, but the newer version, I'm pretty sure they have it because my students are reading from therapeutic choices as well, and they told me that it is there in the book. So take a look at that, and yeah, this is how we do antidepressant switches in practice. Now about the bonus that I have today for our PEBC applicant students, there is a very good course called the Pharma ePass course. I don't know if you heard about it. It's fairly new and not new also. They have a very well organized course for evaluating exams and qualifying exams, with also an OSCE preparation or OSCE training coming up soon. And they are 100% online, so you can enroll into the courses and study from wherever you are. I know most of you are in other countries, not in North America or Northern Canada, so you can enroll and study 100% online. I believe the OSCEs are going to be online too, and this is a very good opportunity for those who are planning to take the OSCEs in the next few months, because you basically can train for the OSCEs without having to travel to Canada. I'm not 100% sure about the OSCEs, but everything else is very well organized, very peer-reviewed, which is very important, and tested. So it should help you with your upcoming exams. I have a discount coupon. I'm going to leave it for you in the description. If you can use the discount coupon as many times as you want, or even share it with friends and family, whoever is planning to study for the PEBC exams, whether it's the evaluating or qualifying exams. It gives you a discount of $200, actually $200 discount, which is fairly good if you're applying for these courses. I know these courses could be a little bit expensive, but yeah, for this course only, I'm going to give you that coupon in the description that you you can use as many times as you want, and hopefully it helps you. And good luck. I know that the exams are happening soon, or a few exams are happening soon in end of October and beginning of November. So good luck for everyone taking the PEBC exams. Let me know in the comments if you have any questions before the exam. I would be very happy to help you all. And make sure to use the Pharma ePass courses to help you with the study as a study guide. Thanks for watching today's video, and until I see you in the next video, have a great day and stay safe.